Good afternoon, everyone. I think we're going to get started. I'm delighted to welcome you today. I'm Maria Carpenter from the library, and I wanted to start by thanking our partners, the library's Programming and Communications Committee, the Humanities Center Artists and Practitioners and Residents Program, and the Northeastern Bookstore for their co-sponsorship of today's program. I also want to give a special thanks to our planning partners, Dr. Carla Kaplan for bringing this idea to us, to Emily Sabo and Allison Rodriguez for their hard work, to Kumi Silva from the Humanities Center, to Sean Mohammed, and everybody else who has pitched in. This has truly been a collaborative opportunity that we seized. And I also wanted to just emphasize the importance of both the Artists and Practitioners in Residence program and the Meet the Authors series. These programs create precious space for dialogue and exploration of ideas on campus. I was at one of the Humanities Center's related events last night, and the panelists were talking about this, the importance of having forums such as today's program that allows us to push ourselves away from the dock. That was the metaphor that was used, and to get ourselves outside of our comfort zones and to explore important issues. I also wanted to make you aware that we are filming today's program. It will be on YouTube and iTunes University channels, and we appreciate your feedback. So did everybody get a comment card? Yes? Come on, yes, raise your hands if you did. All right. Well, you're going to want to fill that in because first of all, it helps to inform the kind of programs we bring to you. And also, there's a raffle today. Woohoo! So you have an opportunity, if you fill out those cards, to, we're raffling off 3 copies of Dr. Sanders' book and a DVD of the first season of House. So fill out those comment cards. You have a chance to win. We're going to be doing a reminder right after Dr. Sanders speaks, and we'll be collecting those. And then at the end of the Q&A, we will draw and announce the winner. Okay, so don't forget to do that. And I want to close by introducing Dr. Carla Kaplan. She will be introducing our featured speaker. Dr. Kaplan is the Davis Distinguished Professor in American Literature, and she writes on modern African American and women's history and culture. She is the brainchild behind the Humanities Center. Thank you, Dr. Kaplan.
Where should I put this? What a great turnout here on the last day of classes. There's tons of room on the floor. And if you are happier sitting on the floor than having to stand, I urge you to come on up and to sit on the floor and to come fill this area in so you don't have to sit in the back. It's really wonderful to see everybody, and I've already ruined something. It's really wonderful to see everybody, and we're so excited about this residency. As Maria has said, this event is part of a 2-day residency with Dr. Sanders, which kicks off Northeastern University's new Artists and Practitioners and Residents program. I cannot think of a more perfect first resident than Lisa Sanders, and now that I've had the chance to come to know her, it is absolutely impossible to imagine a more generous resident than Lisa Sanders. We have given her no time. She's doing more events than anybody possibly should, and each of them has been quite spectacular. This is one of 3 different occasions today to hear Dr. Sanders speak, each of which will be different. And I want to urge you to attend the other 2 as well. At 5 p.m. in the Cabral Center, Dr. Sanders will appear on a panel under the rubric of The Arts of Being, Telling Life Stories Now, with film and cultural critic Leo Brody, sculptor Ellen Driscoll, biographer of Eleanor Roosevelt Blanche Wiesencook, and our own assistant professor Kimberly Juanita Brown, who works on Black women's bodies and photography. There will also, from 6 to 7:30, be an informal discussion on career development and career choices. From 6 to 7:30, great snacks available there. In 201 Mugar Life Sciences, moderated by Dr. Sean Mohammed. And as you'll see in a moment, I can't think of anybody better able to advise people on how to put together unlikely and combined careers than Dr. Sanders. So I urge you to attend all of these events and make it a Sanders extravaganza today. Let me introduce her and then add a few needful thank yous. Dr. Sanders writes the New York Times column Diagnosis, which I know many of us read avidly and wait for every single month. It is the basis for the television show House, for which she serves as technical advisor. Her groundbreaking detective-like approach to diagnosis insists on a multidisciplinary approach to the patient as a whole person. Feel free to come fill in space up here as you come in, folks. Dr. Sanders looks beyond statistics and symptoms and uncovers life narratives. An internist at Yale School of Medicine, she is the author of Every Patient Tells a Story, which will be for sale in the lobby following this talk, and we will have a signing. She's also an Emmy Award-winning news producer. So you see what I mean about career advice. We would not have been able to have Dr. Sanders with us for these 2 days without the support of the Provost's office, the advisory board of the Artisan Practitioners and Residents Program, some of whose members are here today, and I'm really glad to see the advisory board here. The directors and staff of the Humanities Center, Amilcar Barreto, Kumarini Silva, Nikisha Cody, and Jen Sapchachkai. Collaborating units such as journalism, communications, and especially Bouvet and Sean Mohammed. Partners like the bookstore, the Meet the Author series, and the Northeastern Libraries, which sponsors today's talk. But most especially, program administrator Allison Rodriguez, who has been the absolute ever-ready bunny, and Dr. Sean Mohammed. They have done the heavy lifting, and we are deeply grateful to them. So with no further ado, Dr. Lisa Sanders.
All right, this is going to take some coordination skills, so. Okay.
That was it.
Can you hear me? So thank you, Carla, who's got this whole introduction thing down pat, since she has me running everywhere. Thank you for your lovely invitation. You know, a couple of years ago, a friend of mine who teaches here, Elizabeth Dillon, said, you know, there's this historian who is a big fan of your column who sees it as a form of biography. And I was like, huh, biography? Because to me, the stories that I tell are not special stories for me. They are the stories that doctors tell about their patients as we're trying to figure out what's going on. You know, last night I had the pleasure of being invited to the president's house with a whole bunch of really cool people. And they were talking about life story as an art form. But to me, the life stories that I tell, they're not an art form. They're a tool. It's a tool that helps us figure out a patient's diagnosis. I didn't invent this tool. Indeed, it's been part of medicine since modern medicine began, which really wasn't that long ago, really. The turn of the 20th century, the middle of the 20th century, really, was the beginning of modern medicine. And this system of talking about patients, of collecting their information in exactly the format that I use, has been handed down through generations of doctors. This detective story that I tell in my column, and to some extent in this book, is not an invention of mine. I am just somebody who realized that this was a cool story that didn't get told outside of the walls of the hospital. I started my career, my post-college career. I'm not sure I would use me as a role model, however, because all I wanted when I graduated from college was to live in New York City. I didn't have a lot of career goals. I mean, I wanted to do something important, but I wasn't, maybe, or at least well-paying. So I eventually wandered into television. My first job in television was on Good Morning America. There might be a few people in this room who remember the names Joan London and David Hartman. They were the host then. Anybody who's under 40 has never heard of these people. And my first job was to answer their fan mail. I hadn't done it for more than 2 weeks when I realized that this was not really going to work out, and I needed to get promoted as quickly as possible before I just committed suicide. Because it was such a terrible task. In part because of life stories. You know, most of the mail that I answered was not really mail. It was people, you know, writing in for Julia Child's recipe. But at least 10 letters a day, and there were hundreds of letters, but at least 10 of those a day would be these people who would pour out their troubles to these people who they had never met, Joan London and David Hartman, and ask for their help in some way. I almost never could get to the end of the letter because they were so heartbreaking. So I thought, I definitely have to get out of here. So I eventually became a producer and did that and covered medicine for several years. And that's when I fell in love with medicine. And when I realized that television was not going to be my last career, my first thought was, hey, maybe I could get into medical school. You never know. And fortunately, I did. I'll tell you why. Well, I don't know why, if this is really why I got in, but it's certainly how I saw it at the time. When I was in television, I had the pleasure of covering Hurricane Hugo, which was a huge Category 5 hurricane that hit my hometown of Charleston, South Carolina. And that was for a show called 48 Hours. And that show got an Emmy Award, and I got an Emmy Award. And so I didn't even go to the ceremony because I didn't think I was going to win. But we did. And so when the box came, I opened the box, and my first thought, seeing that statue with my name on it and the date, was, yes, now I can get into Yale Medical School. And so I got into Yale Medical School. And the first couple of years of medical school are not fun. Let me just be very clear. I mean, they're interesting, but they're not necessarily fun because it's a lot of this. Sitting around, listening to somebody talk about whatever it is that they want to talk about. 3 lectures on bile. Okay? 3. Bile. It's important. Is it that important? Hard to say. But the beginning of my 3rd year, of every medical student's 3rd year, something amazing happens. They let us loose in the hospital with real patients and real doctors. And there, I heard a story that I had never heard before. Now, I had covered medicine for 7 years. I told a lot of the stories that were being told about doctors. And I heard a story I'd never heard before. And I didn't hear it just once. I heard it every day. Every day, at least in internal medicine, all the residents, all the students, and many of the faculty come together to discuss one patient. It's called resident report. And the patient is presented the way I present my patients in my column, with the chief complaint, the history of the presenting illness, the physical exam, the studies, and then you figure out what's going on. And that was the first time I realized that at the heart of every doctor-patient interaction is this tiny detective story. I had no idea. I really thought that diagnosis was a lot more like math. You know, you work through the problem and then you check the back of the book for the answer to see if you got it right. And if you did it right, you got it right. Well, but diagnosis isn't like that at all. It's an uncertain practice. And even when you get to the answer, you don't know that it's right. You can't flip to the back of the book. Sometimes it takes a long time to find out whether you're right or wrong. And it makes for a very compelling story and a really fun career. So after I'd been writing my column for a few years, I got involved with House. You know, David Shore, who's the executive producer of House, was a big fan of my column, thank God. And a hypochondriac like many of my readers. Not that I'm outing you, Carla. And he called me and he said, you know, I want to do this television show, and it's about this arrogant, irritable drug-addled doctor who hates patients and loves diagnosis. You want to work on it? And I thought, good Lord, this show is never going to go anywhere. You know, I think it was Swifty Lazar says nobody knows nothing in Hollywood, so I definitely didn't know anything. So I did that, and then I realized that there were lots of, that diagnosis was this cool thing that people really didn't know very much about. And watching House might increase people's knowledge, might not. And I wanted to talk about it. I wanted to tell people about this cool thing that happens. And so I wanted to let people see what it felt like to stand at the bedside of a patient and recognize that what you figure out or not could have an important impact on that patient's life. So I tried to tell some of these stories and show what some of the things are that drive a diagnosis, what gets it off track, what works, what doesn't work, and what sometimes happens. But mostly, I mean, it's an opportunity to tell stories, which is something that I love to do. I am from South Carolina, after all. Except my stories are true. And I love the stories that are in this book. I love the stories that I tell. You know, this morning, before I came to Northeastern, I went over to Tufts to Resident Report, which is, you know, this paradigm of this detective story that's played out every day in every teaching hospital, 5 days a week, 52 days of the year, 6 days a week in many places. So I went and I heard my next case. I was like, oh my God, this is such an exciting case. I threw out the case I was working on and found that case. I mean, this is something that happens every day. And if I can just capture a tiny parsec of the excitement, the intellectual excitement that those daily meetings have, then I will have done my job. So I start my book by telling a story about a patient that I had never met at the time. The doctor who figured it out was thrilled. I mean, thrilled. He saved her life, and he wrote to me about this patient. She was, at the time, a 22-year-old woman who had just graduated from college. She had no past medical history. She got sick one day. She got a fever. She felt kind of achy, and she didn't feel like eating. Maybe she had some nausea, vomiting, diarrhea. And she took to her bed for a couple of days. And on the fourth day, she just felt like enough already. And she got up and forced herself to take a shower. When she got out of the shower, she looked at herself in the mirror, and she saw that she was bright yellow. In fact, the nurse who saw her at the hospital, where she went right away, said that she was highlighter yellow. When she got to the emergency room, she was seen by the emergency room doctor, who decided immediately that she needed to be admitted, that she was critically ill. And her care was turned over to the resident and the intern and the attending on the service. And so I'm going to read from the first part of my book about the resident's thoughts as he communicated them to me when he first met this patient. The resident's name is Wagner. Dr. Wagner could feel his heart racing as he stood looking at this jaundiced wisp of a girl lying motionless on the bed. The bright, unnatural yellow of her skin was shiny with sweat. She had a fever of nearly 103. Her pulse was rapid, but barely palpable, and she was breathing much faster than normal. Despite the oxygen piped into her nose, she was breathing much faster than normal, despite the oxygen piped into her nose. She slept most of the time now, and when awake, she was often confused about where she was and how she had gotten there. To a doctor, nothing is more terrifying than a patient who is dying before your eyes. Death is a regular routine in the ICU. It can be a welcome relief to the patient or his families. Even a doctor may accept it for a patient whose life can be prolonged no longer, but not for a young girl who was healthy just weeks ago. These doctors had done everything they could think of, but there was still a fear, a reasonable fear, that they'd missed some clue that could mean the difference between life and death for this young woman. She shouldn't die, but the young resident and all the doctors caring for her knew that she might. Crystal's thin chart was filled with numbers that testified to how very ill she was. Wagoner had been through her chart a dozen times. Virtually every test they'd run was abnormal. Her white blood cell count was very high, suggesting an infection, and her red blood cell count was low. She had barely half the amount of blood she should have. She'd gotten a transfusion in the emergency room and another after she was moved to the ICU, but her blood count never budged. Her kidneys weren't working, her clotting system wasn't either, her yellow skin was covered in bruises, and her urine was stained deep red. Sometimes, if you just work hard enough to keep a patient alive, to keep the blood circulating, the lungs oxygenating, the blood pressure high enough, the body will be able to survive even a vicious illness. These are the miracles brought by technological advances. Sometimes, but not this time. The ICU gave Crystal bag after bag of blood. They did their best to shore up her damaged clotting system. She got medications designed to increase her blood pressure and fluids to help her kidneys. She was on several broad-spectrum antibiotics, and yet none of that was enough. She needed a diagnosis. Indeed, she was dying for a diagnosis. So, not everybody needs a diagnosis. There are patients who come to the hospital, and I joke that they are untouched by human thought. We don't need to think about them. We know what to do. Somebody comes in with pneumonia. We get a chest x-ray. The pneumonia is there. We put them on the antibiotics that evidence shows is going to be the right antibiotic. They get better. They go home. That's it. We don't have to think about what's going on. We know what's going on. But a significant fraction of patients who come to a doctor's office or who come to the hospital are not obvious. They do need a diagnosis, and a diagnosis that will make a difference because it guides therapy. I mean, a diagnosis is just a word. The only thing that's useful about it is that it gives us treatment options, that it tells us what to do that might help this patient. There are patients who have diseases that we can't treat. It's still nice for them to have a diagnosis because it gives them some sense of control even when we don't have any. But sometimes it really makes an important difference. And I think it's important that I think it's important that doctors should understand how important this is, but I think they do. I think it's very important that patients should know how important this is. And that's one of the reasons that I wrote my book. People sometimes ask me what the most important diagnostic tool is. You know, is it the CT scanner? Is it blood tests? I think people have put too high a value on testing to make a diagnosis. Testing doesn't make a diagnosis. Doctors make diagnoses, and sometimes nurses and other health professionals. Sometimes your mother, actually, can make the right diagnosis. But tests never do, because a diagnosis is a puzzle. A disease is a puzzle. And tests don't tell you the answer to the puzzle. There's no way to go to the back of the book in medicine. Because even if you get a test and it says it comes back positive, whatever that means, it doesn't mean that that's what the patient has. Because tests are wrong sometimes too. Every test, if they're honest, will say, test was positive, requires clinical correlation. That is to say, this test says she has this. What do you think? Because ultimately, it's up to putting the whole picture together to make a diagnosis. I didn't know that. And I don't think patients know it either. So many times, especially family members will come up and say, well, can't you just test for it? Don't your tests tell us what's going on? Tests are yes or no questions that we ask technology. And what we get back are, for the most part, yes or no answers. And that's great if you've asked the right question. But if you haven't asked the right question, then the answer is not going to be that helpful to you. It's about thinking. It's about putting it together. It's about collecting the data. Jerome Groopman wrote a book a few years ago, a wonderful book, I highly recommend it, called How Doctors Think. And it talks about some of the difficulties that doctors have in problem solving. I see what he sees, which is diagnostic errors are made. But I come up with a different problem. I think that the problem for many doctors, and this is in the hands of the patient, so that's why I'm telling it to you, is that they don't collect enough data. Up to 90% of the time, the diagnosis is in the patient's story, or the correct diagnosis will be found based exclusively on what the patient has to say. You know, I don't think tests provide, 10%. The physical exam provides another 10%. But most of the time, a diagnosis is based on what the patient has to say. Patients don't know this. I know that patients don't know this because they will often not tell their story. They often, when a doctor interrupts them or cuts them off, they don't go back to their story because they figure the doctor knows what he's doing. I think doctors do know what they're doing. But I think that the temptation to shortcut the patient's story leads us up many a blind alley. Even in-house. Now it's fiction. Still, I was giving grand rounds to some surgeons during the 4th season. So I went back and counted, reread all the scripts for the first 3 seasons to figure out where the clue came from that helped House figure out the case. So it never came from breaking into the house. Okay? All you doctors in here, all of you who break into houses routinely, just raise your hand, a little show of hands. Right? So we don't do that. So appropriately, they didn't find anything out that way. The high-tech testing that they do all the time rarely came up with the answer. Most of the time, the answer came from the patient, him or herself, or the patient's body through the physical exam. So even in-house, the data that you collect from the patient directly turns out to be an important clue to the diagnosis. And I don't think that patients recognize this, because I've never had a patient tell me, excuse me, doctor, I'd really like to finish my story. Could be because I'm perfect and never interrupt them. Could be. But I think more likely it's because even patients don't know how important the data they have is for the patient. You might not know what's important about your story, and the doctor might not know what's important about your story. But trust me, the odds are excellent that there's very, very important data in there, and data that can't be collected any other way except by talking to you. So a gentleman over there asked me about whether we could have diagnosis of animals, veterinary medicine. And I could never be a veterinarian because I don't know how you do it. I don't know how you get the kind of data you need without the patient's help. Hell, I couldn't even be a pediatrician. But the patient's story is the most important part of the data that we collect. And in my book, that's why I named it this. Every patient tells a story. Even though my book isn't just about the patient, what they say, it's always the most important part of the story. And if you're one of those people who tries to figure out the mystery as it's unraveling, trust me, it's going to be in what the patient has to say. Does anybody have any questions? Yes, sir.
Picking up again on the animal theme, I think that the way to get the story about the patient is to talk in the case of a dog, for example. When you go to the veterinarian, or when I went to the veterinarian, they tend to ask you very cursory questions about the symptoms of the animal. And I think that what you're saying actually extends to the animal world if you try to tease out more in-depth information about the, the whole history or the underlying structure of what may be causing, not the disease directly or the symptoms directly, but
That behavior.
So I think that the story, articulating the story may be part of the answer there as well.
And pediatricians tell me that. Pediatricians tell me that the best diagnostic tool for a pediatric patient is the child's mother or father, but mostly the mother. Yes, sir.
What happened to the young woman who turned yellow?
Thank you so much for asking that. This doctor, Dr. Wagner, after caring for her, after she'd been in the hospital for about 48 hours, he realized that they were going to blow it and that the patient was going to die. So he did what we all do when faced with somebody who might die in front of our eyes. We call the smartest doctors we can think of. And so one of the doctors he called, he actually left a note on his chair, was the head of medicine, Steve Wallerstein, and that's the guy who wrote to me. And he came back, he was on his way to play racquetball on a Friday night, and he saw this note in his chair which said, "There's a patient sick as hell in the ICU. Would you please go see her?" And so he put down his gym clothes and headed over to the ICU. He said that whenever he's called on to help people think or figure out a patient, he never reads their notes. He never talks to anybody who was involved in their care. He goes straight to the patient. So he went and he talked to the patient. Now the patient by then was a little confused, but her mother was there and had heard Crystal tell her story so many times that the mother was able to tell the parts of the story that Crystal couldn't remember. And then he reviewed all then he examined her, made a couple of important observations there that had been overlooked. And then he examined her lab data. And while he was looking at that, he sort of closed his eyes to try to open up his mind to see a pattern, because making a diagnosis is often about recognizing a pattern. And two things jumped up at him that had been overlooked. He realized that this patient's liver had failed. They didn't realize that because the labs that we look at to sort of measure how your liver is doing, they were normal. And normally when a liver is damaged, those values go way up. But what happens if the liver's already been completely destroyed? Well, they wouldn't be elevated. So he made that recognition. And he also recognized that her blood was being destroyed by something that was in her system. And he said a bell went off. And he recognized this as Wilson's disease. Wilson's disease is a hereditary disease where a patient lacks the machinery to get rid of copper. Copper is an important essential nutrient, and it's present in food. But we only need a tiny, tiny amount. And your body's job then is to hold on to the tiny amount we need and get rid of all the rest of it. And she wasn't able to get rid of all the rest of it. Most of the time, Wilson's is not that uncommon, but most of the time, people present with abnormal liver values on their blood work and subtle neurological signs, usually a tremor. A tremor is an unusual thing in a young person, and so that's what leads people to one version of Wilson's disease, the most common version. But 5% of the time, patients will present, like this woman did, with acute liver failure. What happens is something releases the copper from where it's stored in your liver, and copper in your bloodstream is very destructive, and it just went through her body, destroying everything it touched. There's only one treatment for that, and that's a liver transplant. And so after spending an hour with her, he recognized what she had. He brought in an ophthalmologist, 9 p.m. on a Friday night. Ophthalmologists don't usually make a lot of calls in the ICU. But he had them come in and bring their equipment, because sometimes you can see a copper buildup around the outside of your iris, a little tobacco brown, golden brown color. He had looked at her eyes with his own eyes and hadn't seen it. But with the equipment that ophthalmologists have, they can see even small amounts. And so he confirmed his diagnosis, but even before confirming it, he had already called Columbia Presbyterian, and he had her shipped there by helicopter. And she got a liver within the next few days. And I met her just last fall. I'd spoken to her over the phone many times, but I'd never met her. And she's perfectly healthy. He saved her life. I mean, it's the kind of romance story that we tell. It's the bodice ripper for doctors, this story. It satisfies everything. We want to be Steve Wallerstein. We all dream of being that someday. So that's what happened to her. She did very well. Yes, sir, and then you, ma'am.
I'm always interested, or I'm very interested in the social dimensions of problem solving. That is, the example you just presented was a sort of brilliant person who put the pieces of the puzzle together, and well, actually, that's not quite a fair characterization of that story. But I'd be interested in your reflection on how much sort of the deliberation among a group of doctors around diagnosing a patient versus, let's say, one doctor pondering the data and coming up with the answer.
Well, I think one of the difficult things in medicine, and it's certainly hard for all of us as doctors, and God, it must be terrible for patients, but we don't usually talk about it, is nobody knows everything. And the kind of knowledge that doctors accumulate is extremely idiosyncratic. It's based on their own interests and the patients they've encountered and the stories that they've heard. Because, of course, medicine is fundamentally a narrative practice. We recognize diseases by hearing those stories, and then we're able to recognize them, as Dr. Wallerstein, who I think is a very smart doctor. I don't think he's a genius. I don't think it requires a genius. But you have to know, you have to have knowledge of a particular disease. You know, in the 70s, when people started thinking about how diagnoses were made, there was an assumption that you didn't have to know everything because everything was now available at your fingertips, you know, in the library. You didn't have to have all that knowledge. You just had to know where to find it. That turned out to be completely untrue. Basically, you can never diagnose something that you've never heard of. You can rarely diagnose things that you've never heard of. It can happen, but it's the exception. And so I don't think that there's any qualitative difference between some guy who happens to be the doctor who came in, who recognized it, and doing what we often do, which is sit around with all of our friends going, what am I missing? What am I not thinking about? What have I not put together? We have this shorthand for talking about patients that's an abbreviated version of the way I write about it in my column, where we can describe the significant aspects of a case. Even if you don't know what's going on with the patient, you can usually figure out what's important. And, you know, just in a shorthand go, hey, yeah, I've got a 22-year-old lady with jaundice and really significant anemia. What do you think this is? And somebody might be able to make that diagnosis. So I think both of those ways are things that we use, relying on our own knowledge and relying on the knowledge of our friends and other of the smartest doctors we know. So, yes, ma'am.
You say that Wilson's disease where the person can't reject most of the copper in their body. So how come that only really manifested itself in her when she was 22? That's 22 years.
So usually, I mean, we take in tiny amounts of copper through our diets. And usually, you don't see any symptoms of this buildup until people are in their late teens or early 20s, and sometimes in their 30s. And it's usually a subtle manifestation, abnormal LFTs or liver tests, and maybe a tremor or some other very subtle neurologic sign. The 5%, they're not sure why this sort of jailbreak of copper happens, but some people think it has to do with antibiotics. So what I didn't tell you about this girl, because I didn't want to take up too much time, was that before she had gotten sick, she had had her wisdom teeth taken out and had a dental abscess that was treated with 2 rounds of antibiotics. And so the thinking is, we don't know this, but the thinking is that maybe those antibiotics triggered this thing that happened to her. Although it's not clear, because in other cases this can happen without any precipitating event. So it's kind of, when I got to medical school and I realized how little we actually know, I realized that if patients knew how much we didn't know, they would be way less likely to come to the doctor. So we don't know a lot of things. Yes, ma'am, did you? Yeah.
Well, I think I have two questions, actually. One is you talked about the patient not realizing the power of their story, essentially. But where in that equation is the responsibility of the doctor who may undervalue the patient's story, or family members who can sort of contribute to that? And is that changing? You may be part of the change by having such a public role in that. And then my second question is, in these crisis situations, it seems like sometimes doctors default to either their siloed discipline or their own sort of local institutional knowledge without going beyond to the smartest doctors they know. So those are two different questions, so take it as you will.
I think the most, one of the things that I say when I present this woman's case, because she had a classic presentation of an unusual disease, which makes her a great teaching tool. And I say, and it always gets a laugh, that when she was admitted to the ICU, they did this, they did that, and she was pan-consulted. So they consulted everybody. Got a kidney doctor because her kidneys weren't working. They got a blood doctor because her blood wasn't clotting. They got an infectious disease guy who was worried about whether she had an infection. She had bloody diarrhea, so they got a gastroenterologist. So each of them came and looked at her through the tiny pinhole of their specialty, and none of them came up with anything, although interestingly, the gastroenterologist says when she recovers from this illness, she should be evaluated for Wilson's disease. You can be so close. So, but, this is my argument for why everyone needs an internist. You need somebody whose knowledge is broad and integrative rather than isolated and very well defined. Because bodies don't always divide themselves up along specialty lines. And very often, a pain in your leg can actually be due to something in your back, something in your brain, something someplace else. So I argue that an internist, people ask whether, like House, there are doctors who are the director of diagnostic medicine. They're called internal medicine specialists. It's what we do. So
Can we just remind people to fill out their comment cards and put your names on them, because they're going to start collecting those for the raffle. Did anybody not get a card? If not, raise your hand. Raise them, raise them, raise them.
Don't forget to put your names on them.
putting what on podcast?
Just putting out just like just as if we were at a round.
Well, it'd be great. Of course, it's doctors talking to other doctors, and if you've ever talked to a bad doctor, you know that they're completely capable of speaking without uttering a single word of English. And that happens, it's when doctors talk to each other, they don't actually speak English. They speak their own dialect that everybody has in their little professional silos. So I don't know if anybody would want to watch it. But more importantly, there's issues of patient privacy and confidentiality,
right.
which are.
Just like the story.
Well.
Almost like basically like your column.
They should read my column.
Yeah.
They should buy my book. Yes, ma'am.
So in most of these medical cases that you talk about, in most of the episodes on the show, the patient rarely dies in the end. But I'm sure that most of the time when people come with these rare diseases, they do go unnoticed. So if a patient dies and a diagnosis is ever reached, like as a physician, does the case just drop off for you, or does it kind of linger and leave you wanting to know the diagnosis even though it's too late?
Actually, I love your question, but let me just say, I think that most patients who die of things that we do understand and recognize. I mean, most people who die at a very old age from, terrible diseases that they've had for a really long time. But there are cases where people die and we don't know the answer. And we used to do autopsies on all those people. But autopsy turns out to be extremely expensive. And nobody wants to pay for it. So sometimes there's an autopsy, but often there isn't. And I know that people want to know. When I was an intern, a patient came in several times over the course of a summer, and eventually she died. And we didn't have a clue as to what was killing her. I mean, I can't, there were many conferences, many resident reports on her, many reaching out to specialists, and finally, after she died, we sent samples of her blood and her organs to the NIH and the CDC to see if they could come up with something, and they weren't able to come up with something. So you think about these things. Somebody asked me if I could remember the first patient whose life I saved. No. But the first patient whose death I could have prevented and didn't, I'll never forget those patients. Those are the patients that live on in your imagination. Those are the patients that never go away. There's a guy who makes a computer system that's wonderful to help with diagnosis. And he said, doctors would be a lot better diagnosticians if they died with the patient. We'd have a lot fewer doctors, that's for sure. But, even though we don't die, I think that the mistakes that we make or the things that we didn't catch or the lives we don't save, they make an important impact. And unfortunately, we all learn best from our mistakes. We think we learn from our successes, and perhaps we do. But I'll tell you, nothing teaches you something like screwing it up. So, yes, sir.
How do you feel about patient self-diagnosis and using the internet to get to that point without a doctor?
I think it's fantastic. I think that anything that makes it easier for patients to engage in information about their bodies and engage in their own health is a plus. It's not that people didn't try to diagnose themselves before there was the internet. They didn't have the internet, they had their mother, they had their friends, they had their colleagues. People talked about their illnesses and tried to figure it out way before there was the internet. The internet makes it a little bit easier, maybe. And that's fine if what you have is low back pain. But one of the problems with medicine is that it's vast, it's huge, and the body has this tiny repertoire of symptoms. So if you have a lung problem, there's a handful of ways your lungs are going to let you know there's a problem. You're going to be short of breath, maybe you'll cough or wheeze, you'll cough up sputum, or you'll cough up blood. Maybe you'll have chest pain. That's it. Thousands of diseases of the lung. 5 symptoms. It's difficult. I mean, it's why diagnosis is difficult. Okay.
We have time for one more question, and then we're going to do the raffle and then the signing.
Yes, ma'am.
Don't you think, too, that very often patients need to be their own advocate, their responsibility for further investigation? If you continue particularly not to feel well and your symptoms progress. Fortunately, I had a situation in my family, one of my own children, who was ailing for a long, long time. He had a crackerjack internment. And when we went and took the chemistries in the bloods, his white count was way off the wall. He sent him to every specialty. They took him to new tests. When he turned jaundiced and lost $15, that everybody was on the phone. He was admitted, and they were all over him on these times. So, nephrology, GI, hematology, every specialty, and finally determined it was his gallbladder.
Wow.
But it was a harrowing experience. He went through agony for months and didn't say it. Went to work. So we were that small fraction that had fabulous practitioners, but very often patients are not addressed.
Well,
They don't like the opinion of they continue to ail. They must take matters into their own hands. Whether you're insured or not, if the last resort is going to an ER, that's what you have to do.
Well, I would argue that going to the ER is not a great choice. It's better to stick with the doctor who knows you. But, and I would also disagree that that it's a fraction of patients who get the right answer. I mean, I think that most patients might take us way too long, but we do get to the answer. It's a fraction of people who remain mysteries. But you're right. It's your body. You have to take care of it and make sure that the doctors who are caring for you are caring for you enough.
Thank you so much, Dr.
Thanks.
Sandy.
Thank you so much.
Before Maria moves us into the next piece, I neglected to thank by name Maria Carpenter, who's done an amazing job, and Emily and the rest of the staff of the libraries. And I'd just like to give them a hand for all the work.
So we're moving on to the raffle stage. Woohoo! And Emily, take it away.
Sure. I just wanted to make sure if there was anyone who hadn't had a chance to submit their card. Speak now, but it looks like we got everyone. Rebecca's going to also come up with 3 copies.